Kiran until Theo is ready.
Thank you. I am Dr. Kiran. Namaste from India. Hi. Hi. Yeah,
Okay.
you can play the video.
Yes. Okay. Let me get it set up here.
Because I was mentored by late Professor Bhagwati and Dr. Panikar. I now work in Bangalore.
Okay. Here we go.
Good morning. I must congratulate and appreciate Dr. Sameh and his entire team for putting up this uh, wonderful show and working so hard behind the scene. I've been noticing since almost past 2 to 3 months. I will today talk about not very, different approaches or exclude some complicated approaches. But what I'm going to talk about is a different approach to a tumor we all commonly see. Pituitary tumors, most of us have operated, and many of us who have operated over the years have realized with all the humility that it is not as easy as we think it is. So, some of the lessons taught by these pituitary tumors I will unfold. Pituitary surgery is a teamwork. As you see, it requires entirely whole team of endocrine, histopathologist, ENT, and of course us neurosurgeons to deal with one tumor. And this is from our team from Narayana Health where I used to work before. This is one typical example which I encountered. This is a large pituitary surgery is a teamwork. As you see, it requires entirely whole team of endocrine, histopathologist, ENT, and of course us neurosurgeons to deal with one tumor.
Am I on camera?
And
If I
this
have
is
a look, because I
from
can't see.
our team from Narayana Health.
Can you turn your camera up?
This is one typical example which I encountered. This is a large pituitary tumor. Of course, the dilemma will be whether to operate transcranially or endoscopically. It is okay, either way we can think, we can argue about it. I decided to do endoscopically and choose to do elective subtotal resection step by step. After initial surgery, I repeated a scan. Within 3 months, you see, because of the necrosis, the pituitary size has come down by itself. Then, after about 6 months, when I repeated, there was hardly any tumor left for me to operate. This is one of the positive or happy endings. Always it will not be like that. I feel the theatrics of the pituitary always is outside the operation theater. Even complete removal, we always have noticed that they come back. And some tumors even resist hormonal treatment or any other treatment. Why is it so? This is always I used to worry, and we search for the answers. There is a different entity which is being recognized called aggressive pituitary tumor. It refers to pituitaries which have early recurrence in spite of complete removal or persistent growth after what we say removal. Initially, WHO in 2004 had talked about atypical pituitary adenoma where there is a high Ki67 index, high mitotic index and P53, etc. Going further, the European Society demonstrated radiological invasiveness and unusually rapid growth rate, and in spite of standard treatment. This they called it as aggressive pituitary tumor. The term again expanding further in 2017, WHO showed some of the pituitary tumors have independent aggressive behavior irrespective of the routine pathology or biochemical or hormonal entities. This different subsets, about 5 of them I've identified, and let us talk about it. First, dopamine agonist resistant pituitary. We encountered about 4 cases. This is a subset of prolactinomas that do not respond satisfactorily to agents. What do we do with that? We change the reagent, operate and keep quiet? No. Because resistance is characterized by failure to achieve normal prolactin in 30% or etc. in a maximum tolerated doses. This is one of the cases where the prolactin was very high, that is 1206, and even after persistent treatment, it remained high. And this patient underwent typical transphenodal pituitary excision. Then, histopathologically, to our surprise, we found MIB index or Ki-67 was 8 to 10%. So this demonstrates the inherent aggressive nature of this prolactinoma that is resistant to medical treatment. This patient underwent radiotherapy in June 2021, and our patient's latest prolactin level is 19, and she is showing very good response. And as you are seeing in post radiotherapy, there's complete resolution of the tumor. And similarly, there was another patient. This is a pre-op MRI, itself looked aggressive. You can see the NOS grading, invasion of cavernous sinus, etc. So this patient, initially, as usual, we started on cabergoline treatment, but it did not respond fully. In spite of maximum dosages, it was 1473. And this patient, we did a decompression and straight away gave radiation in spite of MIB index being 1, because these are medically refractory prolactinoma. We were wiser this time. And this is another case where the tumor looks, quite big. Post-treatment also, the cabergoline, the value was more than 1000 and MIB index was 3 to 4%. We gave post-surgery radiation. So never neglect patients who have, after 6 months of 8 months of treatment, their prolactin does not come down to near normal. Always follow up, because these are very aggressive tumors. This is Chatzeli's as a 4 independent predicting because of resistance to dopamine agonism. They are male, greater tumor volume, prolonged time to prolactin normalization. This is very important. Not only it may not come down, some tumors may take longer time. These are also can be inherently aggressive. Existence cystic degeneration, necrotic component, etc. It is as high as 10 to 18% of prolactinomas. Keep a close watch on this. The mechanism is mainly associated with subtype 2 dopamine receptors, and some have identified different molecular pathways. This is the treatment protocol which is available. And radiotherapy, and some have even tried temozolomide along with it. And as you can see, most of them are in younger age group. They always have, many of them have cavernous sinus invasion. Next, let us come to crook cell pituitary adenomas. We saw about 4 cases, and this is usually occurs in a setting of glucocorticoid excess, but they have a distant hyalinized appearance, and they represent about 6 to 8% of the corticotroph adenomas. We had about 4 cases. Again, most of this in middle age or a younger age group. And this is one case where the cortisol was high, as you are seeing 67, even ACTH was high, and we operated. And as you are seeing, there is a cavernous sinus extension of the tumor, and post-op also there was some residue in the cavernous sinus. This we undergone with the radiotherapy. This is another patient whom we similarly operated, followed by radiotherapy. Crook cell adenoma, the biochemical mechanism is not understood, but is thought to be a result from feedback inhibition, and thus represents a regressive change in the corticotropes. And it is a variant, and usually presents in middle-aged women, and can often have invasive macroadenomas. Most of the Cushing's, as you recall, will be microadenomas. In this case, there will be either macroadenoma or they can involve cavernous sinus. And the next one is we encountered is silent corticotrope adenomas. They are distinct subtype of non-functioning pituitary adenomas, that is physiologically, but they on immunohistochemistry they stain positive for ACTH. They exhibit more aggressive course, probably because they have undergone regressive changes. These are two cases we have seen, and again they are common in younger age group. And as you are seeing, this is one of the tumors where cortisol was normal. It was almost 7. And then post surgery, it was 6. It did not reduce fully. And once we got a histopathology, it showed ACTH staining. These undergone radiotherapy because they are inherently aggressive in nature and tend to recur. They have, what it is proposed that 3 theories are proposed. They have either higher number of lysosomes which destroys the ACTH before it can be circulated into released into circulation. Other secretory adenomas, it is proposed that they are biologically inactive because of the change in the molecular weight. And second, it may originate from the corticotroph progenitor cells. So these are the 3 theories proposed for some. They can be divided into type 1 and type 2. One is densely and another is chromophobic. Recurrence rate is 27 with first one, that is densely granulated, and 10% in the type 2. The last we come is sparsely granulated somatotroph pituitary adenomas. Granulation is very well known in somatotrophs. These are weakly and focally immunopositive for growth hormone. They may have higher growth hormone secretion clinically, but may not be also. They also variably express prolactin, etc. And literature suggests that they respond poorly to the somatostatin treatment. These are the cases we encountered, and this is one example. As you are seeing, again, these tend to be more extension into cavernous sinus, and the growth hormone was 18 and IGF-1 was 459. Even after surgery, it remained high, and hence we chose to do radiotherapy. And this is another case. Similarly, after surgery, even though there was a complete excision, we chose to do radiotherapy because the hormone was not normalized. It was 7.8. These are less common and are composed of sheets of poorly cohesive chromophobic cells, and there is growing evidence that they are densely granulated behave differently from sparsely granulated, being larger, more proliferative, greater capacity to invade, and poor response to somatostatin treatment. This is always not so because the number of cases reported is quite less. And in summary, we had a cases of dopamine agonist resistant prolactinoma, silent ACTH, crook cell adenoma, sparsely granulated somatotrophies. These, in spite of the best surgical treatment, tend to recur, and therefore these should be followed up closely. That's why get all the molecular workup done for all the pituitary cases, not just the immunochemistry or routine histopathology. And literature wise, as you can see, these tend to be crook cell as high as 60% recurrences there in spite of best surgical treatment. And that is why we need to have a close follow-up and never blame. Always we tend to blame that, oh, we may have left some tumor behind and that has recurred. Never always have guilty feeling because we have done the best. The pathology itself is different. And these are the different protocols we can get in a standard literatures. And to summarize, in our experience, aggressive tumors, there are some factors which are independent predictors, and in spite of our best surgical treatment, they can tend to recur and needs close-up follow-up. That is larger tumors in young patients, resistant prolactinomas, extension into cavernous sinus, silent corticotrophs, high K16 index. These are the 5 things which we need to keep a close watch. And in conclusion, treatment of these pituitary adenomas can be challenging, and they lack consistent response to the treatment options. That's why close follow-up is very essential. And as you have seen, multidisciplinary approach of endocrine, histopathologist and surgeons are required to achieve correct treatment. Thank you very much.